A pleasant afternoon to everyone. Welcome to Plenary Lecture 7 of the PSEDM Annual Scientific Convention. I am Chi Añanueva Cruz, and I am delighted and honored to introduce to you today an educator, a researcher, and a visionary. He is a professor of endocrinology and metabolism at the Hacettepe University School of Medicine in Ankara, Turkey. His research interests are androgen excess disorders in women, particularly polycystic ovary syndrome. He is also the clinical lead of reproductive and developmental endocrinology of the European Society of Endocrinology. He is the founder and president of EndoBridge, with the vision of bridging the world of endocrinology by providing opportunities for physicians and scientists with an interest in hormonal disorders to interact and share their experiences and perspectives. And to share his insights and perspectives on polycystic ovary syndrome, it is my privilege to introduce to you Professor Bulent Yildiz.
Thank you very much, Dr. Cruz. It's always a pleasure to be in Manila, but this is my second time, and unfortunately, this would be virtual. And I really like the acronym of the meeting, the HOPE, and I really hope we could get together physically sometime soon. But for now, it is indeed a pleasure to attend this Philippine Society of Endocrinology, Diabetes and Metabolism meeting. And today, I'm going to overview polycystic ovary syndrome. The outline of my talk, we will start with the definitions and significance of the syndrome. Then we move to global prevalence and phenotype differences. We will look at PCOS as a metabolic disorder as endocrinologists. And we look at evidence-based long-term management, and finally, conclusions and future perspectives. So starting with the definitions and significance. When we try to conceptualize a common and complex disorder, we have susceptibility genes, and then we have environmental factors, including the prenatal ones, nutrition, drug effects, and stress. Then you have the disorder, the phenotype of the disorder, and you need to define the phenotype to understand your disorder. When it comes to obesity, definition is quite straightforward. So the phenotype is defined by a number. And when we talk about diabetes, again, the phenotype is defined by a number. But when it comes to PCOS, the biggest challenge for us as both clinicians and researchers is the definition of the syndrome phenotype. But as of today, we know that PCOS is a common hormonal, metabolic, and reproductive disorder. And if we look at the signs and symptoms, we see the most common one being hirsutism and oligomenorrhea. Then we have infertility, polycystic ovary morphology, obesity, amenorrhea. And if you look at the bottom, we see even normal menstrual pattern in some of our patients. So why PCOS is important? Why are we having a talk on this disorder? It is the most common endocrine disorder of reproductive age women. It is the most common cause of anovulatory infertility, and it has a significant public health impact, including cardiometabolic risk and long-term health consequences. The name includes only polycystic ovary morphology, and all the confusion is coming from here because many women who do not have any disorder also show this morphology, and some PCOS women do not have this morphology, but yet we have the only component in the name that's being polycystic ovarian morphology. And how do we define it? With the new guidelines, the 2018 international guidelines, we put the presence of 20 or more follicles in each ovary, measuring 2 to 9 millimeters in diameter, and or, that's important, especially for us endocrinologists, when we do the pelvic ultrasound, the volume is more important. So here increased ovarian volume, the cutoff being 10 milliliters. So either above 10 milliliter volume or more than 20 antral follicles would define PCOM. But then the key question is whether this ovary is ovulatory or anovulatory. And if we try to define oligoanovulation, we look at the literature and there are differences. But what we know is oligoanovulation is normal in the first year post-menarche. Oligomenorrhea is defined by menses less than 21 or more than 35 days or less than 8 times a year. And amenorrhea would be no menses for 3 months. How about hyperandrogenism or androgen excess? The common clinical manifestation of hyperandrogenism is hirsutism. The prevalence is up to 15% depending on the population, and it is the most commonly used clinical diagnostic criterion. If we try to define androgen excess biochemically, we need to use calculated free testosterone, not the direct measurements, that's very important, or free androgen index, or calculated bioavailable testosterone. The others, including androstenedione and DHEAS, would be used only testosterone or free testosterone are not elevated. And the clinical ones being hirsutism, acne, and alopecia. But if hirsutism is accompanied by acne and alopecia, we take into account that they are symptoms and signs of hyperandrogenism, but acne and alopecia alone would not be taken as a clinical sign of androgen excess. To define androgen excess, we use this modified Fairman-Galway score. So 9 regions of the body scored between 0 and 4. Here, one of our patients getting 0.1 from the upper abdomen, 3 from the lower abdomen, and 2 from the lower back, and the total being 6, already reaching to the cutoff we use to indicate hirsutism. To make it easier and more convenient, we also have a photo atlas of hirsutism that's being used in several clinics around the world. Then we look at the phenotype and we see within the same disorder, same syndrome, we have several different phenotypes. And the other challenge is even in the same patient, the phenotype changes, meaning that a patient you are seeing at the age of 18 is not the same patient when she comes to you with the age of 40 or 45. We're going to be dealing with different problems in the same patient with different phenotype. So to make the things easy, in 2012, we had this first evidence-based methodology workshop on PCOS. I'm not going to get into the details, but one result is very important, and we recommend it there, is that the specific phenotypes should be reported explicitly in all research studies and clinical care, meaning that it's not enough just to put the ICD code E28.2 to the chart. We need to say all the components specifically. And if we do that, here within the last few years, we suggest to use these letters, phenotype A, B, C, and D. So when we say phenotype A, this is the complete phenotype, meaning that all 3 components are there. Phenotype B, you have androgen excess, ovulatory dysfunction, but not polycystic ovarian morphology. Phenotype A and B are also called classic PCOS. When we look at phenotype C, we have androgen excess, we have polycystic ovarian morphology, but not ovulatory dysfunction. And finally, the most controversial phenotype, phenotype D, is the phenotype with ovulatory dysfunction with polycystic ovarian morphology, but not androgen excess. So this is non-hyperandrogenic phenotype. So when we see a patient, we say this is PCOS, and then we put this phenotype E, A, B, C, or D. And how about the prevalence of the disorder? So this is the oldest study. This is the US data that we have. And here you see the prevalence is about 7% when you use the NIH criteria, meaning that in this study, we do not have ultrasound. So these are classic PCOS with hyperandrogenism and oligoanovulation. And you see the prevalence is about 7%. If we look at an unselected population with Rotterdam criteria, that's the data we have from Turkey, one of the earliest studies using Rotterdam criteria. And here you see for the NIH criteria, it is similar to US, so around 6%. But when you use the Rotterdam criteria, it goes up to almost 20%, affecting 1 out of 5 women. And if you use the Androgen Access Society criteria, then it is 15%, meaning that it affects 1 out of 7 women. So depending on the criteria you're taking, the prevalence changed significantly. And if we look at all the studies around the world, this is the first meta-analysis of the prevalence studies. It tells us that the NIH criteria prevalence would be 6%, just like the first original study. And with the other 2 criteria, the prevalence is around 10%. But again, geography is very important. Here you see data from different parts of the world. And depending on where you study, your background population affects the prevalence. But look, for example, the NIH criteria, it is pretty consistent across the continents. And what you see here is we need more data from certain parts of the world, especially from Africa and from Russia. And in fact, we have just completed a study in Russia, and the results will be available soon. There are 2 studies going on in Africa as well, and we look forward to the results of those studies. The other thing that we need to keep in mind is the patients presenting to your clinic are not the same with the patients in your background population, meaning that the phenotypes, the prevalence of phenotypes could be different. And in fact, this slide illustrates this fact. If I look at the referral population, meaning that patients coming to your clinic with some complaints, half of them having phenotype A or full phenotype. But if you go to the population and check the prevalence and phenotype of PCOS, what you see is the most common phenotype is phenotype C, in other words, ovulatory PCOS. This is very recent data, and I think it's relevant for endocrinologists. This is the clustering analysis of almost 900 women with PCOS from Andre Dunay's group. That slide showing us that if you do the clustering analysis, you see distinct reproductive and metabolic subtypes. Here with the red, you take these parameters, glucose, insulin, BMI, and you see the blue circle. These patients with SHBG, LH, and FSH seem to be different. And this study also showed us that some novel genetic variants are uniquely associated with each subtype, meaning that distinct forms of PCOS might have different underlying biological mechanisms. In other words, the patients coming to us at our endocrinology clinics might be different from the patients presenting to the infertility clinics, both biologically and genetically, meaning that we need to tailor our treatment depending on this type. And for all these phenotype studies, recently we have published these recommendations, which is very important to harmonize the research, to be able to compare the different results from the different parts of the world. It's very important to follow these guidelines when you do phenotypic research in PCOS. And in fact, in the near future, probably several journals will be asking whether your research is compliant with these recommendations. From there, we move to PCOS as a metabolic disorder, the important part for the endocrinologists. And as we said, PCOS is different in different stages of life. So as a young adult, the patients present to us with androgen excess and oligoanovulation. But when we come to the premenopause, then the metabolic problems would be significant. And the most important one being prediabetes and type 2 diabetes. And this is the classic data. This is a study showing insulin-mediated glucose disposal in PCOS. This is a clamp study, hyperinsulinemic euglycemic clamp, and that shows us that PCOS patients, irrespective of being obese or non-obese, are similarly insulin resistant with patients of type 2 diabetes. So PCOS patients are as insulin resistant as patients with type 2 diabetes, irrespective of body fat, being obese or non-obese. So PCOS has insulin resistance. And then if you do the frequently sampled IV glucose tolerance test to look at the beta cell function, here we see the AIR, and the beta cell dysfunction is there. And this beta cell dysfunction is more significant in patients with a family history. So the PCOS patients have insulin resistance and beta cell dysfunction. So then it's not surprise to see the clinical phenotype or reflection of these pathophysiological features. Here you see the risk of metabolic dysfunction, prediabetes, diabetes, and metabolic syndrome are increased 2 to 4-fold in patients with PCOS. This meta-analysis includes 35 studies, 24, and that's why for the last 13 years, polycystic ovary syndrome diagnosis is included in the list of risk factors for diabetes that is published every year by American Diabetes Association. So PCOS is a risk factor for development of diabetes. So how do we screen? We do 2-hour OGTT, and if the first OGTT at diagnosis is normal, then depending on the risk factors, we plan OGTT either annually or biannually in normal glucose tolerant women. One thing to emphasize is you can use every measure of insulin resistance in your clinical research studies, but in your clinical practice, no test of insulin resistance are necessary to make diagnosis or to select any treatment. So in routine practice, you do not need to measure insulin resistance or looking at insulin levels. How about obesity? We know about 50% of patients presenting to the clinics would have obesity, but of course, it will depend on your background population. Once you have obese PCOS patients, they have android distribution, they have worsened insulin resistance, lowered sex hormone binding globulin, adverse lipid profile, and increased risk of type 2 diabetes. How about gestational diabetes? This is the single meta-analysis that I could come up with from the literature, and that tells us, even though the data is quite heterogeneous, overall, the risk of gestational diabetes is increased 3-fold in women with PCOS. We look at PCOS and obstructive sleep apnea. The prevalence of this disorder in PCOS is around 20%. And in some studies, we see up to 10 times increased risk. And that's why it's important to question the potential symptoms of obstructive sleep apnea, especially in obese women with PCOS. How about cardiovascular disease? This is the most important one. In fact, we do not have a lot of long-term prospective follow-up data. But if you look at the pathophysiology, starting from menopause, you have impaired fibrinolysis, visceral adiposity, insulin resistance, and androgen excess. All could lead to metabolic dysfunction, endothelial dysfunction, and atherosclerosis. So it's very important to assess this risk. And in fact, there's one very recent meta-analysis looking at that, and that tells us the risk of hypertension, non-fatal stroke, and coronary heart disease are all increased between 40 to 80% in women with PCOS. How about the first degree relatives? Many years ago, we asked this question: if women with PCOS are at increased risk of metabolic dysfunction, what happens in their first degree relatives? So this is the first study systematically looking at that question, including mothers, fathers, sisters, and brothers. And we were surprised with the results that the prevalence of metabolic dysfunction was quite high in first degree relatives. In fact, the combined prevalence of IGT and type 2 diabetes in mothers and fathers were about 46 and 58% respectively. So half of the parents having diabetes. And even more importantly, all of IGT cases and 62% of patients with diabetes were undiagnosed before screening. And similar to the proband, similar to the patients with PCOS, fasting plasma glucose was normal in 50% of newly diagnosed diabetes, meaning that if you just measure the fasting glucose, you have quite high chances of missing the glucose intolerance, very similar to our patients with PCOS. And the brothers and sisters, because they were young, we have observed insulin resistance, but not diabetes yet. So then, after this study, there were several others looking at the same question. That's why we had two meta-analyses, and these are the only meta-analysis because it's quite difficult and challenging to collect all the patient-level data. That's what we did from all around the world. And the first one, looking at diabetes and insulin resistance in all first-degree relatives. And here, what we see, the relative risk of type 2 diabetes in mothers, it's 2.4 times increased. In fathers, 2.3 times increased. Sisters and brothers, they do not have the phenotype of type 2 diabetes or increased risk because most of them are still quite young, but especially mothers and fathers show increased risk of diabetes. And then if you look at the metabolic syndrome, hypertension, and hyperlipidemia, the other components in first degree relatives, the results are pretty similar. So the mothers and fathers have increased risk of metabolic syndrome, and sisters, even they are younger, have statistically significantly increased risk. So the odds ratio is about 1.5, and the brothers do not seem to have increased risk at early age. So apparently, not only PCOS patients, but also families are at increased risk of metabolic dysfunction. And then the key question is, should we screen these individuals when they present to us? So we need more data in this field to make this kind of recommendations. What is new in PCOS and metabolism? New kid on the block, as you are very well aware, is the gut microbiota. Now, several groups in the field of PCOS are working on gut microbiota and PCOS. When we looked at our patients, I'm not going to get into the details, but what I can tell you is there are alterations in gut microbiota in both lean and obese women with PCOS. There are also changes in important molecules that are coming from gut microbiota, including this TMAO, that's a very well-known cardiovascular risk factor for the development of coronary heart disease. And what we also looked at in humans for the first time was whether these alterations in gut microbiota changes with treatment in women taking oral contraceptives. And what I can tell you is OCs do not affect the gut microbiota composition, at least for the 3 months. So this is an emerging field, and hopefully we will have more data in the near future. From there, I want to move to evidence-based long-term management of PCOS. So this is non-fertility management. And if you look at the literature, we first had this consensus on women's health aspects. This conference was organized by ESHRE and ASRM. This was in Amsterdam in 2012. Then we have a guideline from the Endocrine Society. Then we put a position statement from the European Society. And finally, in 2008, we had this international guideline. But even for this most recent international guideline, when we developed these recommendations, what we see was quite striking. Here we have 166 recommendations. Only 31 of them are evidence-based, 59 are clinical consensus, and 76 are clinical practice points, meaning that we really need more research in PCOS to inform the guidelines to develop evidence-based recommendations. And what I can tell you, by the way, since we are endocrinologists, are most of these evidence-based guidelines were coming from the RCTs in infertility field. So for us, for endocrinologists, for the long-term management of PCOS, non-fertility management, we even need more data. How about lifestyle interventions? So starting with that, we would recommend to every patient. So healthy lifestyle behaviors are important for all PCOS. Lifestyle intervention, including diet, exercise, and behavioral strategies should be recommended in all women with PCOS and excess weight. So this is an evidence-based recommendation. In women with PCOS, there is no or limited evidence that any specific diet is better than another. So this is a clinical practice point. So as long as you reduce the calories, it doesn't make any difference to play with the macronutrient component of your diet. So any diet is not better than the other. How about the pharmacological treatment for the long-term management? We need to pay attention to individuals' personal characteristics, preferences, and values. All drugs we are using are off-label, but there are studies. But officially, in several countries, you would see we are using drugs that are off-label for PCOS. So we need to discuss the evidence, concerns, and side effects with our patients, emphasizing this fact, and consideration of pharmacological therapy alongside education, lifestyle, and other options, including cosmetic therapy and counseling. So pharmacological therapy in and itself is not sufficient. We need to pay attention to education, lifestyle, and cosmetic therapy as well. Starting with the combined oral contraceptives, COCP alone should be recommended in all adult patients with androgen excess and irregular menstrual cycle. So this is the number one drug we are using. And you can use these drugs in adolescents with a clear diagnosis of PCOS, but you can also use them in adolescents who are at risk. One thing to emphasize is specific types or doses of progestins, estrogens, or combinations cannot currently be recommended with inadequate evidence in PCOS. Practice should be informed by general population guidelines, meaning any OC is good for long-term management, but there's one exception, that is 35 microgram ethinoestradiol and cyproterone acetate should not be considered first line as per general population guideline. As you know, from the general population data, there are some concerns regarding venous thromboembolism. That's why cyproterone acetate should not be the first line, but all the other OCs are as good as the other. So we do not choose one over another. Why? Because we don't have data. When we have data, probably we'll be choosing some over the others. How about the combinations? OC plus metformin. That combination should be considered in adults with PCOS for management of metabolic features. So if your patient has IGT, then it's a good idea to combine these two drugs. These could also be used in adolescents with PCOS who are overweight. And these are most useful in patients with high metabolic risk, including diabetes risk factors, IGT, and high-risk ethnic groups. What I want to emphasize here is when we developed this guideline, this data was coming from just 6 randomized controlled trials. So again, the evidence base is quite weak, even for this very generic recommendation that I'm sure many of us already using in the clinic. How about the OC and anti-androgens? This should be considered to treat hirsutism after 6 months or more of OC use and cosmetic therapy have failed to adequately improve symptoms. Even though I'm a member of this guideline development committee, my personal approach is for severe cases, I might prefer to start combination therapy from the beginning, not losing 6 months. And I'm sure some of you would agree with me. But the problem is we need to develop the evidence base for this because we do not have RCTs. And for androgen-related alopecia, the combination should be used. And if you will use anti-androgens alone, then it's very important to use the effective contraception. If there are contraindications to OC use and you want to use the anti-androgens for a woman with androgen excess, other kinds of contraception would be very important to avoid male fetal androgen virilization. And also, you need to pay attention to potential liver toxicity. So we need to check the liver function. And all these requirements, again, it might be surprising to you, but just based on 4 randomized controlled trials, meaning we need more data. How about the anti-obesity medications? The recommendations are as per general population. And as I said a minute ago, when you use anti-androgens alone, then you need to use an effective form of contraception. To summarize in a diagram what we say, so we have a PCOS patient, education and lifestyle is very important. And then we move to the first-line pharmacological therapy. First-line pharmacological therapy would be oral contraceptives. We use lowest effective estrogen dose. We look at metabolic risk profile, side effects, cost, and availability. We follow the general population guidelines. We do not use 35 microgram ethinylestradiol plus cyproterone in the first line. And for hirsutism that is not responsive to your first line OC, you might add an anti-androgen after 6 months. And you should pay attention to the PCOS related risk factors, including high BMI, hyperlipidemia, and hypertension when you prescribe an OC. And here we see the second line pharmacological therapies. On C, with the OC, you can have metformin, you can have anti-androgens, or in patients only with metabolic problems without any clinical problems of androgen excess, you might choose to use metformin and lifestyle combination. So how to conclude? PCOS is a common and complex hormonal, metabolic, and reproductive disorder. Women with PCOS have increased risk of type 2 diabetes, gestational diabetes, metabolic syndrome, and obstructive sleep apnea. Obesity increases the risk of metabolic dysfunction in PCOS. First-degree relatives of women with PCOS, similar to probands, have increased metabolic risk. Preliminary data indicates potential role of gut microbiota in metabolic dysfunction of PCOS, and we need more data on this. And finally, OCs are still the first-line pharmacological agents for long-term management in PCOS. So thank you for your attention.
Thank you, Professor Yildiz, for your incisive perspectives on polycystic ovary syndrome. It offers new knowledge for clinicians managing patients with PCOS. It also piques the interest of our young researchers to answer important questions. But above all, it instills hope for our patients with PCOS and allow us to present to you our certificate of appreciation for your very good and very true learning experience that you provided for us today here at the annual convention. Thank you once again.
Thank you very much.